the serum calcium was on a lower side and phosphorus was on a higher side, and the patient's vitamin D wasn't very low, probably towards the normal side. How should we proceed with this case? Serum creatinine. So the PTH and creatinine were done in this case. The PTH and creatinine both were on a higher side. So probably it was secondary hyperparathyroidism related to the renal pathology. I have just taken the data from our laboratory to show that we get questions saying that whether it is a linear or non-linear relation between creatinine and PTH levels, because the patient keeps on following both the things up and they say that my creatinine has come down but PTH has not equally improved. So what I just want to show that nowhere can we see any linearity between the creatinine values and the PTH which are measured. In this case there is again hypercalcemia and low phosphorus. The creatinine is also slightly on a higher side. Vitamin D is normal. So how we should proceed with this hypercalcemia?
Could be early renal insufficiency.
Yeah, what happened is the patient had gone for X-ray, I think the same one, and he had osteolytic shadows. So orthopedician was strongly suspecting multiple myeloma of a elderly, he was young, relatively young male, and he went on insisting for that, and we were not getting evidence because serum protein electrophoresis per C was normal, and we got non-secretory multiple myeloma.
I must, before we even proceed, the moment you find an abnormal creatinine in a patient of hyperparathyroidism, of hypercalcemia, first suspect multiple myeloma.
Right.
Because if there is kidney involvement, it has to be myeloma.
Right.
And practically nothing else.
Right.
And as you said, it could be non-secretory.
There could be was needed in this case, and obviously bone marrow was done, and further
because
all in
creatinine otherwise is never high in primary hyperparathyroidism.
Right.
Unless there is obstructive uropathy because of stones or chronic stone disease but generally not.
Right. Then in the case number 5, we have the calcium on a higher side. The phosphorus is also maybe normal to high, and very high levels of vitamin D. The creatinine level was normal. So it was the vitamin D toxicity. The PTH levels were also marginally on a higher side in this case. Only because we are finding additional hypercalcemia along with the higher values of vitamin D, that we are thinking more in terms of vitamin D toxicity.
Why is the PTH so high? That's the only question.
Right.
We didn't do a 125, no? The only other differential is actually a lymphoma or a granuloma producing vitamin D.
Granulomatous.
But again, vitamin 25 hydroxy D should not have been so high. It's still probably vitamin D toxicity only. And I just take up 1 minute from discussion in the morning. I mean, I don't want people to go away with the impression that nothing happens if you give vitamin D. There was a lot of talk in the morning about toxicity, and the orthopedicians don't see it because they don't go to them later. And we keep seeing the hypercalcemias. And it is definitely known, it can occur, and you cannot give vitamin D like that in large doses. It's out of question. It has to be
monitored
as per what is recommended. You cannot go beyond that dose, because otherwise you run into a serious chance of developing hypercalcemia, which can be a serious disorder.
Right. I've just shown a table with causes of primary hypercalcemia. In PTH mediated one, the primary hyperparathyroidism is the most common, and in non-PTH ones, this malignancy associated, which we saw, and vitamin D intoxication. The case number 6, we have vitamin D on a lower side, calcium as well as phosphorus on a lower side. So we got the PTH done. The PTH was also low. 125 vitamin D was normal in this case. So probably primary hypoparathyroidism. So is this commonly seen?
Primary hypoparathyroidism?
Very.
No, not a common disorder.
And this would be the sort of investigations which you would
Phosphorus.
require?
Phosphorus is surprisingly low. I don't know why. Generally, it should be high.
Higher side. Because, yeah.
We'll have to search this. I mean, this will have to be pursued a little bit. The only abnormality here too, which is jarring, is the low phosphorus.
Right.
Generally, we would expect a high phosphorus. Now, the only other situation where you will get this kind of a report is a patient who has undergone, say, thyroidectomy, and his parathyroids are preserved,
Right.
but they are stunned, as it is called,
Right.
usually by vascular insult. They can present with hypocalcemia, but it's a temporary hypoparathyroidism. So you get a low PTH. And the way to differentiate between temporary hypopara versus permanent hyperpara is to go by phosphorus. If
Right.
phosphorus is normal, it usually indicates temporary
Temporary.
deficit.
Transient.
High phosphorus indicates permanent knockout of
Parathyroid.
the
Parathyroid.
parathyroid. So the only surprising thing is the phosphorus
Phosphorus
level,
being on
which
a
is
lower
low.
side.
I don't know why it is. The other thing,
So in this case, maybe urinary levels of calcium and phosphorus can help in confusion?
yeah, so the only other thing which we need to suspect in this patient is a hypophosphaturic osteomalacia, which is a known condition. Primary hypophosphatemia is the
Right.
name of the condition.
Right.
And sorry. Oh, I'm so sorry. The condition is called primary hypophosphatemia or hypophosphaturic osteomalacia,
Right.
or it's also called tumor-related osteomalacia. There, the primary abnormality is a very low phosphorus. See, this phosphorus is really very, very low,
Right.
1.6. The typical manifestation is osteomalacia, otherwise looking like osteomalacia, but having a very, very low phosphorus and otherwise relatively normal patterns. PTH responses actually don't go up. That means generally we would expect that with a little low calcium you would have a high PTH. PTH doesn't go up with hypophosphatemia. So the other thing to suspect here is hypophosphatemia. Hypophosphatemia is of two broad types. One, it's a genetic X-linked disorder, and the other is any tumor of the mesenchyme. So bone, retroperitoneal tumors, cartilage tumors secretes a substance called FGF23, which actually causes this kind of a typical defect.
Fibroblastic growth factor.
Yeah, so should be
Right.
worked up from that grounds, because
Right.
you are seeing a normal 125,
Yeah.
non-elevated PTH, a relatively okay vitamin D,
Right.
and a very, very low phosphorus.
Right.
So rather than primary hypopara, I would label this as hypophosphatemia.